Thank you, sir. I would be talking to you about role of intracameral moxifloxacin in prevention of post-cataract surgery and ophthalmitis. Okay. So there are no financial or proprietary interests. So cataracts, इसको डायरेक्ट लगा दो ना, इसमें है डायरेक्ट.
So till the time she sets up, how many of you use intracameral? I think more than 50%.
I was avoiding it till the Arvind publication came out, and that was so conclusive.
So now have you shifted?
Yes.
In all cases?
Every single case we use.
So it is the most commonly performed, cataract surgery is the most commonly performed intraocular surgery, and incidence of endophthalmitis ranges from 0.05 to 0.1%. And it has decreased in incidence has occurred over the last decade. So as far as the prophylaxis is concerned, preoperatively we all do give topical antibiotics, povidone, iodine. Intraoperatively use intracameral antibiotics, and postoperatively use topical antibiotics as well. Whenever we are talking of endophthalmitis, it is important to talk about the organisms, and I think in India, gram-negative infections are very common, followed by fungal infections. Now, the AIOC2024 endophthalmitis prophylaxis survey did show that intracameral antibiotics were being used 30% in 2007, then increased to 50% 2014, and 84% respondents said that they would use it if approved formulation was available in 2014. So as Dr. Lalit Verma sir was alluding to, you have cefuroxime, moxifloxacin, vancomycin, and cefazolin, which have been studied intracamerally for prophylaxis of endophthalmitis. The ESCRS study did look at the role of prophylaxis of postoperative endophthalmitis after cataract surgery, and it was a large multicentric study, a prospective RCT of 16,603 patients, and there was a 5.86-fold decrease in the rate of culture-positive endophthalmitis. So this strongly supported the use of intracameral cefuroxime. The only thing is that you have to get it to the right concentration in a pharmacy. So concerns also were the fact that emergence of the resistant gram-negative isolates may be there, and the fact that you have to prepare it in the pharmacy. Vancomycin is a broad-spectrum action antibiotic, is effective also in preventing post-op endophthalmitis, but there was a risk of hemorrhagic occlusive retinal vasculitis, and I think that is something why vancomycin did become unpopular. So if you look at the pros and cons, moxifloxacin preparations are available commercially. It has got wider spectrum of action, and it has concentrated dependent killing, unlike cefuroxime, which has limited activity against gram-negative bacteria and needs to be reconstituted. And this was the publication on the hemorrhagic occlusive retinal vasculitis, which I was referring to after vancomycin. Intracameral vancomycin, if you look at the efficacy studies, the efficacy studies have been done for prophylaxis at Arvind Eye Hospital, and they have shown in a retrospective study of more than 1 lakh patients that there is a 4-fold decrease in patients who are undergoing the manual SICS. And this was, again, a follow-on study for an analysis in more than 6 lakh patients, which also showed that the endophthalmitis reduction was there with intracameral moxifloxacin prophylaxis. It was also noted that the PCR increased the endophthalmitis rate by 7 times, which is 0.48%. And if you use intracameral moxifloxacin, then it reduces the endophthalmitis rate to 0.21% in those cases where PCR had actually occurred. There were several other groups also who conferred to the same finding. This was from Japan. There was a 3 times reduction in endophthalmitis with no evidence of any TAS. Then this was again a study from Europe, which looked at the role of intracameral moxifloxacin 0.5%, which again showed that there was no significant difference noted in endothelial cell activity, endothelial cells count, or in pachymetry. And this study looked at the safety of prophylactic intracameral moxifloxacin, again to see that there was no adverse event noted on vision, IOP, endothelial cells, corneal thickness, or in terms of AC reaction. As far as cost effectiveness analysis is concerned, it is found to be cost effective given the fact that it is preventing such an important complication. This was the first survey that we did, All India Ophthalmological Society survey, way back in 2017. And in that survey, at that time, almost 54% of the users or AIOS members said that they do not use intracameral moxifloxacin. About again half of them, they did say that in high-risk cases, including systemic risk, they would prefer to use the intracameral antibiotics. So when we compare it with the ASCRS survey, which was done in 2014, we found that the difference between the two is that moxifloxacin, our AIOS members wanted to use moxifloxacin more, whereas in the 2014 surveys, they were using more cefirixime, moxifloxacin, and vancomycin almost in equal proportions. And surprisingly, 46% said that they were using subconjunctivals also, but that was in 2017, but I don't think that happens now. This was a study where safety and efficacy of intracameral cefirixime, moxiflox, and vancomycin was done at the end of the cataract surgery, which was, in fact, a meta-analysis. And this was yet another study which looked at safety and efficacy of intracameral moxifloxacin in a large number of patients, which is 3,640, and they did not find any significant difference in terms of visual acuity, IOP, or corneal thickness. Now, this is the most recent survey that was conducted by the All India Ophthalmological Society, and this clearly showed that out of 1,804 total respondents, 58% said that they were using intracameral amphotericin B, intracameral antibiotics, and which is to say that if you compare the practice patterns from 2017 until now, these seem to have changed. From 1/3, now they have increased to half of the AIOS members who were using intracameral antibiotics. So our study is a randomized control trial, prospective study, where we've used intracameral moxifloxacin, and we also, Sadhguru Netra Chikitsalaya Chitrakoot is also a part of our study. And this was actually an interim data of 16,000 patients when 8,000 were present in each of the groups. Our mandate is to complete 22,000 patients, and we are nearly there. We've done 21,000 patients, and 1,000 patients are remaining. In terms of the mean age, gender, and type of cataract, there was no difference between the two groups. Also, in terms of the intraocular pressure, endothelial cell density, and corneal pachymetry, there is no difference. In terms of the way the surgery is done, whether incision size, type, location, IOL optic or haptic, again, there was no difference between the two groups. And the parameters that we looked at was the visual acuity, intraocular pressure, endothelial cell density, pachymetry, and systemic adverse events. And there is no difference when you compare it in those cases where you give intracameral moxifloxacin or you don't give it. Now, important thing is that number of cases with endophthalmitis in the intracameral moxifloxacin group that we had was 14, and in the control group that we had was 24. And none of the patients developed endophthalmitis, had intraoperative PCR in either of the two groups, and there were no ocular systemic adverse events which were seen with intracameral moxifloxacin use. Having said this, there is an ASCRS advisory which says that you have to be careful in using the concentration of the drug drug and the quantity of the drug. So both of these things are very important because you have to recommended volume to be injected is different for these two concentrations, and incorrect dosing can cause TAS or endophthalmitis. So one has to be careful about this because few cases of not exactly TAS but some anterior chamber reaction were noted by some of the users when incorrect concentration or incorrect amount was used for prophylaxis of endophthalmitis. So as far as the conclusion is concerned, intracameral moxifloxacin as of now is safe and efficacious in prophylaxis of endophthalmitis after cataract surgery. And of course, it cannot substitute or it cannot be given standalone because you still have to give topical antibiotics post-operatively. We are yet to analyze our data of 22,000 eyes and we would be coming out with the findings soon. But the interim data analysis of 8,000 that we did at that point in time did not show any difference between the two. Now, the difference could be because of the fact that all our cases were done at tertiary eye care center, where all the quality control is definitely there, whereas the studies which are being, which reported 1 lakh cases and 6 lakh cases are being done in larger number of patients, and not possibly all of them are in tertiary eye care center, but they are at in-camp settings. So that is why the difference could be there. But having said this, the complete analysis is yet awaited for 22,000 patients. So thank you very much for